Good evening, everyone. Welcome to our virtual open house. Thanks so much for joining on this evening. We're really excited to kick off this year's recruitment season and showcase our program. Trying to advance my slide. Let's see here. There we go. There we go. Tonight's agenda includes introductions of our panelists. We'll do a brief informational presentation about our program, and our chief residents will talk about what it's like being a resident in Iowa City. We will close with a question and answer session during which we will include both questions previously submitted and questions you send us tonight through the Q&A text box. And tonight's session is being recorded and will be posted on our website for you to view later. I included this photo of a beautiful Iowa landscape just outside Iowa City. You can see the meandering rivers and streams and those lovely rolling hills, which look amazing from this view. But when you're down there on a bike, be it a road, gravel, or mountain bike, these hills are deceiving and they're pretty tough. But I'll get back to this photo later. So let's meet our panelists. I'll start. My name is Andrea Swenson. I'm the Residency Program Director and have been since 2014. I was a resident here sometime this century, followed by a neuromuscular fellowship at the University of Illinois at Chicago. An opportunity arose to come back to Iowa's faculty, and I was really excited to do that. I enjoyed my residency here a lot and like the idea of getting to work with the University of Iowa faculty again. At that time, I was offered the position of Associate Program Director, and after 6 years in that role, I transitioned into Program Director. And now I'm entering my 10th year. I've really enjoyed building upon an already awesome program, which just turned 86 years old. So working alongside our residents has definitely been one of the most rewarding aspects of my career, and I look forward to seeing what the future of neurology has in store. So I'll let our next panelists introduce themselves. Tracy, do you want to go next?
Sure. I'm Tracy. I am Vice Chair for Education and partner in crime with Dr. Swenson. I did my residency at Mass General Hospital and Brigham and Women's Hospital in Boston, and then did a fellowship focused on autoimmune and infectious disease there, and was on faculty and actually was a residency director there before moving to Iowa in 2018. My wife is from Iowa, and I'd always heard great things. And what sold me on moving to Iowa was when I met the amazing residents. That's such an important part of coming to work for me. So I have not been disappointed, and I'm in my 5th year here. I'm also the clerkship director and the proud program director of a neuroimmunology fellowship as well. And I look forward to talking with all of you tonight. Lama, you're next on the list.
All right. Well, hello, everyone. My name is Lama. I am originally from Damascus, Syria, and that's where I did my med school and then moved to the US for residency. So I did my residency here at the University of Iowa. So I have the tremendous pleasure of having my mentors here, both Dr. Swenson and Dr. Cho, and now I get to be their colleague. So I am currently one of the associate program directors for residency, as well as the associate clerkship director. I have also done a fellowship here at the University of Iowa as actually, in fact, the first neuroimmunology fellow under Dr. Cho. And I currently get to do what I've always wanted to be when I grew up. So I've always had a lot of interest in medical education, and I was part of the clinical neuroeducator track here through our residency, which I'm pretty sure Dr. Spencer will talk about in a little bit. And now I get to practice this on the day-to-day basis and get to interact with all of our trainees, which both involve our amazing residents as well as medical students. And I have Jeff next.
All right, hi everyone. My name is Jeff. I'm one of the associate program directors. A little bit about myself. I was a resident here, like many others. I left for a couple of years to do extra training in clinical neurophysiology and epilepsy. And then I was fortunate enough to have the opportunity to return to University of Iowa once I was done my training. So some of my career interests, I'm really interested in education, and particularly in clinical neurophysiology and EEG reading. And so one of the reasons I was excited to come back to Iowa is because of the huge emphasis in education here. So heavily involved in the clinical neurophysiology fellowship too, and we're getting ready to start a epilepsy fellowship. So I'm excited for the opportunity to get involved with that creation. Next, I'll pass it off to Adriana.
You're muted.
I'm muted. Fixed. Sorry about that. My name is Adriana Rodriguez. I was also a resident here with Lama. We were in the same class. I am originally from Caracas, Venezuela, and I did my medical school there, moved to the United States for residency as well. So I stayed here in Iowa for residency, and then I did actually 2 years of neuro-ophthalmology fellowship here at the University of Iowa as well. And I recently joined the neurology department, and I'm doing headache and neuro-ophthalmology, and I'm also one of the newest associate program directors. And I couldn't be happier to just be back in the neurology department and with my colleagues. And just like Lama said, I can't believe I'm doing what I always dreamed I would be doing. So it's amazing.
Hey everyone, I'll jump in really quickly before we go to the Chiefs. I'm Caroline, the coordinator for the program. Welcome everyone. If you have any questions at any point, feel free to enter them in the Q&A box and we'll get to those. I will pass things over to Khan.
Hi, welcome everyone. I'm one of the chief residents. I'm originally from Istanbul, Turkey. That's my hometown. I grew up there and I did med school also in Istanbul University. I was interested in clinical epilepsy research as a medical student, but then I did some research in dementia, Alzheimer's disease genetics, and biomarker studies. And then I was interested in behavioral neurology dementia, and that's why I'll be going in fellowship. So welcome again. We're here for your questions. And I'll pass it on to Mackenzie, I guess.
All right. Hi, everyone. I'm Mackenzie. I'm one of the chief residents as well. I am originally from Golden, Colorado. I came out to Iowa for medical school and really enjoyed it. Really enjoyed people that I was working with. So stuck around for residency. And happy to say I'm sticking around for fellowship in vascular neurology. So we're looking forward to that next year. And I will pass it to Tyler.
All right. Hey, everyone. My name is Tyler. I'm an academic chief this year. I'm originally from Dallas, Texas. I went to medical school in Austin, University of Texas, and my next step will be staying as Lama had mentioned and Dr. Cho had been talking about. I'll be staying in the neuroimmunology fellowship here next year. So very excited about that.
Great, thanks everyone. And thanks again for joining us this evening. I think it's super cool that you all have chosen the field of neurology. It's a fascinating specialty. It's very dynamic, changing all the time with new treatments and technology. At the University of Iowa, when you walk around the exterior and the interior, you get a sense of how far we've come in medicine. Here's a photo from 1940 of the hospital's main entrance with this elaborate Gothic tower that stood above everything at the time. But fast forward to today, The tower is still there. It's got a new name, Boyd Tower, that was given to it in the 1970s. But as you can see, it's now buried amongst the more modern buildings surrounding it. As time has gone on, there have been more and more buildings that have cropped up on the UIHC campus, both research and clinical spaces. The University of Iowa Hospitals and Clinics is a 866 bed facility with a new 190 bed children's hospital attached to it. But there's more to this picture. So right across the street from the University of Iowa campus is the VA hospital, the Iowa City VA hospital. Here's a picture of it here. So this is a 60 inpatient bed hospital, and we do a lot of clinical work at the VA. So it's nice to have both of our hospitals right next to each other. And within UIHC, there are reminders of where neurology has been, like this iron lung, which is located in the medical museum on the 8th floor of the hospital. It's really worth checking this place out because they have a lot of cool things there. And now our residents get exposure to the latest advances in neurological research and clinical care, as you see in this photo of Dr. Ortega, who's one of our stroke neurologists and a neurointerventional surgeon. The overall goal of our program is to provide the best neurological training for our residents that fulfills their career goals, whether it's practicing in the community, working at an academic center, or becoming a clinician scientist, and doing so in a welcoming, supportive environment. We do this by providing comprehensive clinical experiences, high-quality education programs, and empowering both residents and faculty to contribute to and collaborate in advancing our program forward. As the field of neurology has changed, so have we. These changes have been experienced in our program, have come about with collaboration between faculty and residents. We really value resident feedback and rely on our residents to help us move forward. Every month, we have a house staff meeting. Caroline, our associate program directors, and I attend that meeting with all of our residents. Each month we have a new agenda. We go over what's going well, what's not going well, and what needs to change. And there's been a lot of enhancements to our program coming out of those collaborations. So our clinical experiences begin with PGY1 or intern year, which is a combination of rotations through internal medicine, psychiatry, and our surgical and neuroscience ICU. During that first year, we feel it is important to also rotate through neurology. And this is to help start building the neurology foundational knowledge, gain exposure to the field, and hang out with and get to know the neurology team. Our interns spend 4 weeks of their year with us on the neurology inpatient service. And new to our program this year is 4 weeks doing neurology outpatient clinic. But potentially the best part of the PGY1 year is the last rotation of the year, which is our neurology immersion block. So during this no call, no clinical duties rotation, our PGY1 residents go through an intro to neurology with focus on emergencies to get ready for being on neurology call, workshops like learning how to do a lumbar puncture, and the basics of EEG and EMG. We've also set up a lot of different simulations, including code strokes, status epilepticus, and new this past year, we did myasthenic crisis, SIM, as well as Guillain-Barré. We do a lot of team building and retreats. Prior retreats for the PGY1s have included a day at the lake, bowling, and this year they went to a trampoline park, which was a lot of fun. So as I mentioned, our program champions for change and really values contributions from residents. A big change that got significant input from residents is our clinical PGY2 through PGY4 curriculum, which is based on an X+Y model. This has been in place since 2019 and every year has gotten better and better. Our residents really like it. So every resident has their own continuity of care or COC clinic, which allows residents to have their own patients and really develop rapport with the patients who call that resident their primary neurologist. COC clinics used to occur every week despite the rotation a resident is on. We found this to be disrupted to both inpatient duties as well as clinic duties, so we changed it. So X is a number of weeks of a specific rotation. Currently, our PGY2 residents have 3 weeks as their X, and the PGY3 and PGY4 have 4 weeks for their X. And Y is 1 week of COC clinics combined with subspecialty clinics, and we've also included some administrative time for residents. We have found this to be less disruptive and actually improved the continuity of our COC clinics. It provides a predictable schedule for planning weekends off. And also with this schedule, we found other benefits specifically to the PGY2 year. So during PGY2, our residents get quite familiar with treating neuroemergencies and taking care of really sick inpatients. In addition, we feel it is very important to give our residents as early and as much exposure to the different neurology subspecialties as we can. And often this is accomplished in the outpatient setting. So we've put together theme weeks where the PGY2 resident can focus on a particular subspecialty clinic that week. So examples would be a week of neuromuscular clinics, a week of movement disorder clinics, a week rotating through the sleep clinic. With this, our residents can see what fellowship opportunities are out there. Also, we were able to build in some PGY2 elective time for them to explore interests. And here's a sample of the Y or COC week. We do have COC clinics at both the university and the VA, and residents really appreciate taking care of the two patient populations. Our PGY2 and PGY3 residents spend about 5 months on inpatient services, which include our stroke team, general neurology team, and inpatient consultation team. The PGY4 residents, about 4 months. For call, we do have a night float system, which is 1 week at a time, and that's 6 nights. The PGY2 is the junior on the night float, and either a PGY3 or PGY4 joins them in-house each night. And our residents really do like the 2-person call team, which provides a lot of support for the junior resident, and the senior resident gets more autonomy. Of course, we do have multiple faculty members who are on call every night, and they are readily accessible for questions and support for the residents. We're excited to offer many different types of electives for our residents. I've listed some of the more common choices. Our residents really enjoy the advanced neuroanatomy elective and also the ability to collaborate with a faculty member to create and develop their own elective. We have a strong partnership with neurologists throughout the state of Iowa, and through that, we have been able to develop a community elective where a resident can rotate with a neurologist outside of the University of Iowa and experience a community practice. So as our residents progress through their training, there is graduated responsibility, and the PGY4 year is designed to further hone neurological knowledge and skills and really prepare our residents for independent practice. Our PGY4 residents serve as role models, mentors, and teachers for all of our trainees, both residents and students. And we are proud to highlight our most recent graduates. Here's a list of where they are right now. As you can see, many of them choose to stay at the University of Iowa as either fellows or faculty. So how did we get here? Well, here at Iowa, we provide our residents with a well-rounded clinical experience, exceptional didactics, and a multitude of research opportunities. We're the only academic medical center in the state of Iowa, so we have a very diverse patient population with great cases. Not only bread and butter neurology, but also plenty of rare diseases. Our faculty represent multiple neurology subspecialties, so residents get exposure to all aspects of neurology. We have a didactic curriculum that residents participate in every day at noon, which features pretty much all of our neurology clinical and research faculty. This past year, we started monthly concentrated didactic sessions. This is a 2-hour didactic session from 12:30 to 2:30 on the second Thursday of the month. We do provide lunch and protected time from clinical duties with faculty, fellow, and APP coverage. These sessions focus on high-yield clinical neurology topics with board review. A few of last year's sessions included approach to neuropathy, approach to muscle disease. We had a neuroimmunology extravaganza and approach to headache and migraines. These sessions have been really informative and residents have rated them quite highly. We also host weekly grand rounds with internal and external speakers. There are additional conferences throughout the week, including neuro-oncology, tumor board, muscle pathology, brain cutting, neuroanatomy lab. So a lot happening to supplement residents' clinical encounters. For the entirety of our didactic curriculum, we utilize resident feedback as well as in-service exam scores to tailor didactic sessions to our program's needs. For research opportunities, there's many mentors to guide resident scholarly projects. We are a site for StrokeNet and NeuroNext, which allows us to be a site for multiple clinical trials. For the stroke trials in particular, residents are an integral part of our acute stroke trials and getting patients enrolled in a timely fashion, oftentimes while the patients have just been rolled into the emergency room. Residents can also jump in on basic research, educational research, as well as projects in quality improvement. We have creatively designed tracks within our program to enhance residents' educational experience. The Clinical Neuroeducator Training Program, or CNETP, provides training in the foundations of medical education as well as educational opportunities with learners. Residents in this track acquire skills to become effective educators, develop and implement scholarly projects with the goals of becoming future education leaders. And as was mentioned earlier, we're honored to have 2 of our CNETP graduates, Drs. Abdel Wahed and Kardak, on faculty and in the roles of associate program directors. Also, a cool thing about our residents is that they are excellent teachers. They have been awarded multiple teaching awards from our medical students. We also have a formal tutoring program. Residents tutor students on the neurology clerkship. This is designed for students who are looking for additional support, whether it's going over neuroanatomy or discussing clinical neurology topics. And residents get paid for this as well. Another track we have is the Clinical Neuroscientist Training Program, CNSTP. It's designed for trainees interested in pursuing a career in academic neurology who have already demonstrated proficiency in biomedical or clinical research. This unique program is supported by an NIH grant. It provides close mentorship and flexible scheduling to balance research and educational goals. Additionally, 2 of our faculty, Drs. Aldridge and Zhang, graduated from our CNSTP and have their own labs and have secured competitive independent funding. We value diversity, and we're committed to creating a supportive environment for everyone on our team. Within our department, we have created a wellness, culture, and belonging work group, which supports our residents by sponsoring events such as a lecture series and book club that promote discussion and education about cultural knowledge, bias, racial disparities, and skills for contributing to a welcoming, inclusive, and equitable workspace. We've also set up multiple social events for our residents. Our wellness team has compiled resources for mental and physical health, including facilitating resident access to primary care providers and mental health providers. We're continuing to develop strategies to reduce burnout, finding ways to decompress and discuss challenging and difficult cases with each other, and helping each other achieve work-life balance. We provide enhanced mentoring both at the faculty and peer level, and have check-ins from leadership. I do meet with residents individually to see how things are going throughout the year. We want to connect with our community and do this by bringing awareness of neurological disorders and providing shadowing opportunities for undergrad students from underrepresented in medicine backgrounds. Our faculty and residents staff the newly developed neurology clinic within the University of Iowa Mobile Clinic. This is a largely student-run clinic for underserved and uninsured populations throughout Iowa. So our chief residents will be jumping in here to discuss life as a resident in Iowa City. But before they do, I want to get back to this photo from earlier. This is the photo of the picturesque rolling hills of Iowa. But here's the full photo, and you can see the wing of an airplane here. And this photo was taken by one of our residents as they were flying. So here we have Con Dennis and Eigen Asgarli, two of our residents who are co-pilots with Dr. Imada, who's one of our clinical neurophysiologists. So some of the residents are not only becoming neurologists, but becoming amateur pilots. So Con, Mackenzie, and Tyler, I turn it over to you.
I feel like the pilot might want to go first here.
Really, I don't know. We'll see. So life as a resident in Iowa City, maybe I should start with where we mostly stay and how we go to work. So there are lots of varieties in regards to where you can stay in Iowa City. You can have a small house, affordable house, or you can rent an apartment building. You can walk to work, or you can be at 20 minutes distance by driving. So it's very convenient to get anywhere in Iowa City. Everything is very accessible. And it's a very nice, vibrant college town. You get to do the artsy stuff, cultural things, cultural events, and it's a very close-knit and vibrant community, and without the disadvantage of a big city as a resident. So I walk to work. It's a 15-minute walk through a nice little forest. I get to see rabbits and deers every morning, and then but a lot of different residents, live in a house and go to work, and they drive. So lots of varieties, and you can choose among them. I can also say that Iowa City is the UNESCO City of Literature. I don't know if it matters that much, but what it means is a lot of famous writers are invited to Iowa City, and you get to participate in book readings, and it kind of creates that cultural environment here in Iowa City. So I'm very happy to live in Iowa City as a resident. It's very easy to live and very convenient. Yeah. And you get to fly with Dr. Yamada too, so he teaches you how to fly. So that's the other advantage.
Yeah, well, I can jump in too. So I have the perspective of moving here to Iowa City from Austin, Texas. So I can definitely say that the traffic gets a lot better and a lot easier to work with. Can definitely second the affordable living and housing, and I live in an apartment a little bit further away from the downtown area, still in Iowa City, and I'm to the edge of the Iowa City limits basically, and it still is about a 12-minute drive in. So really not a huge place. Much of it in the downtown area and adjacent to the hospital. A lot of that is very walkable place to place. And ever since college and being in Austin, I've really enjoyed college campus, college sports, and I've enjoyed going to football and basketball games. So that's always fun to do. I like to golf. I'm terrible at golf, but there's some great golf courses, and I stick to the driving range, and Con joins me there sometimes. Um, and I have to pick him up because that's a little bit further outside of town. Then I never was really into biking, but that seems to be a necessary thing here in Iowa City. Very enjoyable and a lot of conducive paths and relatively friendly throughout the city. Just riding bikes on some of the roads. So some people I know commute to work on their bikes. So yeah, all of the above. Plenty of things to look for and keep you busy.
Yeah, I can put in my 2 cents. So I actually live in Coralville, which is just like the sister city of Iowa City. It's pretty continuous. You can't um really, there's no separation between the two. I'm on the Coralville side of things, which is really nice. It's not quite as busy as like Iowa City itself, even though busy for Iowa City, super busy in comparison. A lot of like big cities. Um, and it's about 8 minutes commute from my house in like the suburbs of Coralville to the hospital. One thing I really like about Iowa City is it is a big college town. There's undergraduate, medical school, nursing, pharmacy, dentistry, all sorts of different um, students and educational programs. So that tends to keep the city, I think, very young and active. There's a lot of festivals, especially in the summer. We have like a barbecue festival, a jazz festival. Pretty much every weekend there's something. A lot of farmers markets, things like that. So I think it's a great place to live.
So we did have some questions that were sent to us prior to today's session. I will just bring those up and our panelists will answer them. So one of the questions is, what is the patient population like, and how does that factor into the clinical training received during residency?
Yeah, and I can jump on and answer that. The patient population is very diverse, and we cover a very large geographic area. So it's unique. The situation we have here in Iowa City, as Dr. Swenson mentioned, we're the only academic hospital in the state of Iowa, and we're a tertiary referral center here at this main University of Iowa hospital. So what that means is we get frequent referrals from local hospitals throughout the state of Iowa, and also even in surrounding states. We meet patients from Missouri, Illinois, Nebraska, and we get referrals from hospitals for a higher level of care, for an academic level of workup and consideration of differential diagnoses. And so all of these things come to us. What this means is we get to see many rare things that are presenting atypically, things that are really helpful for a resident to see and learn and get familiar with. This is coupled with the other hospital that we work at. Dr. Swenson mentioned across the street, showing you the picture of the Veterans Affairs Hospital. So we also have inpatient work there, and we also have a continuity of care clinic over there. So this is where we get to see more of the bread and butter of neurology. I think that's the phrase, the bread and butter. But the migraines, and headaches and neuropathies and dementias, many of these things we see and follow in our continuity of care clinics in both places, both hospitals, but especially at the VA. And one other aspect to mention, so being that we're the tertiary referral center, it's very different from working in a rural hospital or smaller hospital setting, but we get good exposure and good insight into what those settings are like, just vicariously, one, by just reviewing all of the charts that get sent to us frequently on these referral patients, and also speaking with these local providers. We're tuning in and taking notes on the stroke calls. When we're on the stroke team, we have calls coming in from providers concerned about TIA or stroke and getting recommendations from our experts here at the University of Iowa. And so we're getting a glimpse into patient care in these facilities and how we provide a unique perspective. So all of these things really come together quite well for resident preparation, I would say. So.
Thank you. Some other questions. Can you provide insight into the mentorship and supervision structure within the neurology program?
Sure, I can take that one. At least I can give how it was for me as a resident and now from the faculty perspective. And I'll have Mackenzie answer how it is currently from the resident's perspective. So we do have huge focus on mentorship here, both from we have every resident gets assigned an official mentor where they review their milestones, how they're progressing, and meeting at least twice a year. This is a much more organic and flexible process than it sounds. So you do have that safety net where you get assigned a mentor, but you can have multiple mentors throughout your training. So if you differentiate later on during your training and decide, oh, I actually want to do this, so you can talk to multiple faculty who are doing this specific subspecialty. You can have more than one mentor. I like to think of myself as the aunt with the tea, so people just can walk into my office and we can sit down and chat. So really, I remember as a resident that I could feel free to talk to any faculty about anything that I had on mind, and everyone was super welcoming and super supportive. So from that perspective, it's very flexible and everyone really wants your best interest. So you can have both your clinical mentor, your research mentor, your life mentor, you name it, and it's available. There is also a lot of, when I was a resident, we had a lot of inter-resident mentorship. So I'll let Mackenzie talk a little bit more about that.
Yeah. So yeah, I'll just something what you said about kind of the mentor, the faculty mentors. I think personally, I've kind of changed my mind a lot of times over residency about what I want to do, and every time I changed to something else, faculty in that subspecialty was more than happy to welcome me. On the residency side of it, I'd say it's a little bit more informal. We used to have a more formal process where residents, seniors would get assigned to juniors. Now it tends to be more of an informal process where, especially the juniors, as they're trying to figure out what subspecialty they want to go in, can go to the different seniors that are going into those subspecialties and ask for advice, and the different application processes, what goes into the different fellowship options. So that's been really good, I think, for both of us on the senior side and the junior side to be able to have that open communication. I know at least the stroke group, since I'm biased towards that, but a lot of the residents, both juniors and seniors that are interested in stroke, get together frequently, just one, to hang out, but two, to also talk about fellowship options, the program at Iowa, how we can improve it, things that we like. We're able to provide feedback to each other about different places, that like I interviewed for fellowship, or things I liked in the program and things that they should consider, and vice versa. Yeah, overall, I'd say we're a really close knit residency group, and that mentorship process is very informal, but I think a very good one that we have in place.
Another question, do you consider all applicants equally, referring to MDs and DOs and international medical graduates, and what criteria do you look for in a potential resident applicant? I can take that question. So as far as looking at applications, we do review all applications. I work with our associate program directors as well as Dr. Cho on the applications, and we look through them pretty thoroughly. We have a holistic review. We don't have a score cutoff for the USMLE tests. We don't have a range for when people graduated. So we look more at the application as far as a person's interest in neurology, what types of things they've done during their medical school and after, and if it seems like they would be a good fit for our program. So we do view all applicants equally and are really interested in seeing what they have done and what they're interested in. Criteria we're looking for in applicants, definitely people who are really interested in neurology, have a passion for neurology, and you can tell that that's what they want to do with their career. Also, people who get along well with others, a good team player, someone who likes to step in and work alongside their peers, is going to look out for their peers. And also people who are flexible and adaptable. In the field of medicine, all kinds of different things can crop up, and as physicians, we really need to be able to adapt to that. So those are the things that we're looking for in a resident, and the things that we look at in an application. Other questions? Can you talk a little bit about fellowships that graduates choose?
I can take this question. So I'd say there's not one fellowship in particular that most of our residents go to. I think that's a strength of a program like this, is we have so many strong, well-represented divisions that different residents find they get excited about different opportunities, or able to explore those opportunities further. So I can think of, in my time as both a resident and then coming back, we've had trainees go into stroke, neurovascular radiology, neuro-ophthalmology, sleep, neuromuscular, clinical neurophys, epilepsy, movement disorders, and even rare ones like sports medicine. So with regards to location residents choose to do fellowships, I think probably about a third of our trainees stay here at the University of Iowa. So I'm really proud of that myself. I think it's a good place to train. And I think the fact that many of our residency graduates decide to stay here for fellowship is a sign that they really value their education here and want to see it further. For residents who are looking to spread their wings and go other places, just thinking of my seniors, juniors, and co-residents, really we're all across the country. So I know we have East Coast representation in Boston, Southeast Florida. We have some in Texas, California, Utah, the Dakotas, all over the country. And that's something I really noticed going to conferences too, is with such an old established program as the University of Iowa, we have graduates everywhere. And people get really excited about seeing on, my sticker, University of Iowa. They'll come up and talk to me, say, I went to University of Iowa for this. So there's a strong network everywhere, I guess. And I really appreciated that when I was looking for fellowship opportunities, where almost anywhere I'd apply for fellowship, they'd be like, oh, so-and-so went to the University of Iowa. We should meet with them. So I'd say well represented across different subspecialties for fellowship, and then also well represented across the country.
Yeah, I can also add to that Jeff said. I feel like in my time as well, I noticed that there is a good representation of different multiple subspecialties and good exposure to all of them. But there's also good mentorship to guide our residents into what they want to do, whether they choose to do fellowship or not. There's mentorship for both routes. And we have several graduates that have gone to do general neurology. In fact, one of my newest colleagues, Ryan Lechtenberg, that decided to do general neurology and stayed as a faculty and didn't pursue fellowship. And so that's also encouraged. But I feel like a great advantage and one of the biggest strengths of the program in the university is that if you want to explore different areas and you're not sure, there's many different subspecialties to choose from sleep to sport to neuro-ophthalmology, which is what I decided to do. And we're very strong in all of those areas. And I agree with Jeff, going to conferences all over the country, you meet with people that recognize the University of Iowa as a great, strong neurology program that just graduates strong neurologists in different areas. And we also have the great strength that a lot of us choose to either stay or come back to the University of Iowa, which also I think speaks volumes, because I could not be happier to have stayed here. And Jeff went out, spread his wings, came back. And I think that is part of what makes us great.
I can make a quick comment if you have time for this question. So one aspect of our program that I really like is at the VA, we have our own clinic. You can turn it into a subspecialty clinic if you want, if you're dedicated into a subspecialty. So I run basically a cognitive clinic at the VA, and I diagnosed my first temporal dementia, a prodromal synucleinopathy, prodromal Lewy body dementia, primary progressive aphasia, like very rare entities as well. I see those at the VA clinic. And I think as a resident, it's very valuable before fellowship. It helps you narrow down your interest and make sure that this is what you want to do for the next 50 years of your career, because it's hard to tell before without seeing patients, and it helps. So.
Yeah, thank you. Thank you for that. I totally agree with all that the three of you said. So another question, can you tell us more about the clinician scientist track?
I can take that one. I'm also interested in research heavily as well. So it's a nice, flexible program. It's a track that is designed for like residents who are interested in becoming a clinician scientist. It can be flexible if you want, in a way that it can be a formal mentorship, or if you prefer that way, or you can have multiple mentors simultaneously. And it basically helps you develop your research skills that you already developed a little bit, but helps you keep going with research during residency. So a part of the track is also dedicated for R25 funding. Not all residents do that, but in the CNSTP track, if your grant application is found to be eligible for NIH, or an NIH application, then it can be sent as an R25 funding, which gives you additional time to do research during fellowship. So it secures time for your fellowship to do more research at the same time the time that you see patients during fellowship. So that's one advantage of the CNSTP program. If you're interested in the track, you have to declare your interest beforehand. I think Caroline answered the question. She mentioned an email that you can send if you're interested in the program. That way we can find you, relevant mentors in the program, and that might be, of help to you. So if you're interested, just make sure that you declare your interest early on. Otherwise, it's a very nice track. I mean, we all have the same amount of elective, but what CNSTP gives you is a structured research time. You can gather all your electives together to finish your project, to get some preliminary data for your next grant application. It can be a K award, or it can be, more like R1s and stuff like that. So it's a structured way of doing research and doing residency.
Yeah, thank you. And also for people who are interested in it, letting us know before you apply is helpful, but we have had residents who've started in our program and didn't know that this was going to be a career path for them. And once they got to our program and met faculty members and did rotations and got in on research projects, they realized that they wanted to take that route. So we have had residents join in the CNSTP later on. Another question from the submitted questions, how's the learning atmosphere?
I can take this one. I would also love to hear from Mackenzie, Tyler, and Con on this question, because there's what we're shooting for, and then there's what is experienced on the other side. In general, I think Dr. Swinson touched on this when she talked about the kind of residents that we're looking for. Basically, our culture is one of collaboration and support. It's not an intimidating or high pressured environment in terms of how we learn, how we ask questions, how we give feedback. But my personal philosophy, which I think resonated when I came here in 2018, and one of the reasons that I thought I would be a good fit here, is that I like to get to know trainees and know them at a personal level, so that whenever there is feedback, it's clearly coming from a point of caring about the trainee. And also, I readily admit when I mess up, or which is daily. I also like to keep it light, and self-deprecating humor is my MO, although sometimes I will pick on other people. So the learning environment in general, I try to get people to call me by my first name. I have the hardest time getting them to do it, but it's kind of that first name type of place, even though Iowa has this weird laid back attitude, but formal way of calling each other doctor. And we're all in it together. So I guess that's kind of a roundabout answer to the learning environment, but we're all here to learn. I'm learning every day. And so I start by saying when I don't know what's wrong with the patient or what the right thing to do is. And I think that goes a long way towards residents and students and patients, for that matter, being able to ask questions freely, and also admit when they're not sure about something. So hopefully that's what's being experienced on the other end, but maybe our chief residents can chime in on that question.
I can definitely second that as a learner in my fourth year of many. I think that it's been a very good experience for me, just to be along the way, always feeling like I can ask questions, not being judged for not knowing things, but always being able to learn from other team members, learning from my senior, sometimes learning from my juniors, and learning from medical students. Everything always goes both ways, and we're always open to learning. I would also like to point out we've mentioned a couple times the emphasis on teaching that we have here in this program. And the best way to learn is to teach. I know that's cliche, but I think that we've all lived that and can second that. Teaching a point that seems pretty simple helps us realize that there's more to learn, and a great way for reinforcement. So all of this all ties well together. So.
Yeah, one thing I would like to mention is how supportive the leadership is of making sure that residency is a very educational experience. Like Dr. Swinson mentioned, we now have the immersion, or not the immersion block, the dedicated didactic sessions that are once a month for 2 hours, just protected, dedicated time for us to be able to learn from different subspecialists and have that time where we're not getting caged and not having to worry about patient care. I think that's been a huge benefit to the residency, and something that the leadership's been really good about implementing and now protecting now that it's been a thing.
Maybe
I
go
can
ahead,
give
Tom.
a quick example. So sometimes, like when the services are busy, one resident can ask for help with the lumbar punctures, and when that's the case, we never think that that person is pushing away that duty. It's just that we know that they are in need. So there's always someone that steps up and helps with that procedure. That kind of speaks for the collegial environment in the program, and we never question when someone is in need of help. Then we never question. So that's one aspect that I like about our program. We help each other. I think is the most important thing in a residency program.
There are a few questions in the Q&A, and one of them ties into what Mackenzie was just talking about. The question I think maybe best for the chief residents to answer is how responsive is leadership to feedback?
Yeah, I think the didactic sessions are just one example of many that the leadership has changed based on feedback. Another one, is changing to the expert supply schedule. That's been a huge change. And even just simple ideas, you can go to leadership with an idea as silly as it may sound, and they'll support you. At least so far, I haven't done anything to beyond their level of support. But for example, this year we implemented a new program, Pastry with Pals, which is once a month we get together and eat pastries and try to get our PGY1 since they're off doing their medicine for most of the PGY1 year. Try to get them to come so that we can get to know them a little bit better. But we proposed this idea and leadership was really supportive of it. And now we get extra pastries, so that's exciting.
Another example that the leadership is supportive with, is we've hired a lot of MPs to help out with the stroke team. That kind of reduced the responsibility of the stroke residents. So that's one example how the stroke team structure has changed by hiring additional MPs to the non-teaching service. So that's also another example. I also want to clarify that this can be a point of confusion. We have the didactic sessions. We also have noon conferences almost every day. So the learning keeps going every day, but it's just that the didactic sessions are protected and the pager coverage is provided. So I just wanted to clarify that.
And just to second all of that, we've seen that residents have had a really all residents have really had a good response to feel like they've been heard with having questions and concerns about the program, about their clinical experiences, about experiences in the clinic on various inpatient services. There's many different things that have come through that we've talked about, that we talk about in our house staff meetings, especially Khan and the chiefs have been developing a list of questions, a list of concerns, and Dr. Swenson is there, and other staff are there to discuss, and Dr. Swenson and Tracy, you have to call him Tracy. They have been excellent advocates for us, and now having Dr. Abdel, Dr. Karduk, it's a great team to be working with, and I have unique perspective of working with Lama when she was my senior resident, and now is helping out with the residency program, of course, and so it's been a good experience all the way through. So I can definitely vouch for that.
The next question brings up a really important point. I will just read it. After a review of your website, I recognize that there is not a single Black resident represented in your program as far back as 2017, which is the last year we have on the website. Although ethnically diverse, which is well appreciated, I notice a significant gap in racial diversity. What are specific underrepresented in medicine initiatives built into your program to address this gap, and any outcomes? And I'll let Dr. Swenson answer that first.
With this question, our department has been working very closely with the university, particularly on the hospital side. So there's the University of Iowa with the undergraduate and graduate schools, and then there's also the University of Iowa Hospitals and Clinics, which has the medical school tied to it. So we do have a DEI collaborative that spans the entire university system, and then we have one that's more focused just on UIHC. So our department has been working really closely with them on specific initiatives that are geared towards people going into medicine. So our thought is that you want to get people exposed to neurology, in our case, or medicine in general, at an early age. And so we've developed things like shadowing in our clinics that are specific for undergrad students that are coming from underrepresented medicine backgrounds. We've also developed a medical student rotation for fourth year medical students to rotate with us, and that is set up for students with URM backgrounds. We've also looked at initiatives at the high school level. So there is a Black Youth Summit in Iowa City every year, and that's something that our department is looking to get involved with. So we really want to kind of start at those younger ages to get people interested in neurology and also interested in neurology at University of Iowa. The state of Iowa is not known to be very diverse, but when you look at the 2010 census and compare it to the 2020, specifically in Iowa City, the Black and Hispanic populations have doubled over the course of that time. So we are becoming more diverse, and there are initiatives that our department is working on with the university as a whole. The part of the question was outcomes. These are all fairly new programs that we've put in place, so we don't have any outcomes as of yet, but we're very active within our department to get these things going and hopefully making a difference. One other thing to highlight within our department is our diversity, equity, and inclusion book club, as well as our lecture series. The book club started a couple years ago. It was held every 2 months, and we read a book or watch a documentary. We also read a few articles and some YouTube videos. So it's a pretty quite a different variety of mediums that we would use for the book club. But it was developed to really educate ourselves and to make sure we have the knowledge that we need to really make our department more diverse and really think about different cultures and health disparities. And that's been a really, really great program that we put together. I definitely have learned a lot from it. We also have an ongoing lecture series, which has included speakers within our department and coming from outside our department within the university, as well as speakers external to the university. And that has also been a really great experience and really wonderful learning opportunity for all of us.
I may add something to that, Dr. Swenson. As a female Hispanic physician in the state of Iowa, and having been part of minority and part of the DEI book club for a while when I was still a resident as well, and seeing in general how diverse not only the department but in general the hospital and the other programs at the university, and seeing how that has continued to just go in the right direction within the past 5 years since I got here. And working closely with both departments, neurology and ophthalmology, I can definitely tell that there is a huge effort to have broad representation for minorities and underrepresented minorities in medicine, including Hispanics, female population, and Black population. There is an initiative of Black residents in white coats and Black men in white coats. And I know there's some residents in different subspecialties that are part of these initiatives. So I know that it is still a work in progress, but I think we're definitely part of the change and we're heading in the right direction.
I would just reemphasize the importance of increasing the number of underrepresented medicine applicants for neurology. we definitely screen and invite applicants with diversity in mind. And the more applicants from underrepresented and medicine backgrounds, the better for everyone, and the more likely that we are going to be able to recruit someone to Iowa. So it takes time and a lot of effort and some luck, I think, to get momentum. And I think another aspect is at the faculty level and having additional recruitment from underrepresented and medicine groups to help have mentors and to help draw recruitment at the resident level as well. So those are things that are we have much work to do, absolutely, but it is definitely something that is a priority. But thank you for bringing that up, and I think it's important for every program to look at, and hopefully we will have more colorful photos in our resident classes to come. Other question, I'd be interested in hearing about experiences in the community and the advanced neuroanatomy elective, specifically if anyone has participated in those. So I know Tyler's participated in in our neurology free clinic. So that might be something to touch on quickly, Tyler. And then I'll let any of the residents, current or prior, who have done any of the other community experiences or the neuroanatomy elective jump in.
Yeah, so the resident involvement in the free clinic has been on a volunteer basis. We got this started about a year ago, piloting some involvement in an establishment that had already been created and med student run through the University of Iowa, this mobile clinic. Mobile meaning multiple sites throughout the city and also some surrounding cities, some outreach locations. So some of those locations are directed directly towards a particular population in need, and then of course the places throughout Iowa City and Coralville, just where most of the population resides. So I've had the chance to be a part of some of those clinics, and particularly we have one that I've been to several times at the Coralville Public Library, and we've had a few different experiences on different days. It's variable. You never know as far as clinically what you're going to see. It's a walk-in clinic. We've seen so it tends to be people that are underinsured or otherwise underprivileged and financially restricted for other reasons. And we've had families come in, and one or multiple of their family members wanted to see a neurologist for a variety of reasons. Headache or various pains have been frequent questions for us. Other times there was actually a University of Iowa student who his parent was visiting from out of the country and was needing some healthcare and obviously didn't have insurance. So these are the types of situations we find ourselves in, and it has been a wholesome, refreshing experience to try and get involved in that type of clinical care. And also a pretty interesting scenario where you don't have you're not elbow to elbow with an MRI scanner or the continuous EEG on the other side. So it requires a little bit of clinical reasoning there too.
Has anyone participated in the advanced neuroanatomy elective?
I have not, unfortunately. Maybe Mackenzie, but a lot of our residents participated, and I cannot I personally not, so I cannot say for sure. But it's usually provided by Dr. Sipla, I believe, and you get to spend your week or which however you choose, or 2 weeks in the neuroanatomy lab with a neuroanatomist, going through tissue sections, and it's a very rewarding experience. So, but I have not done it personally. So, have you done it, Mackenzie?
No, I'm hoping to do it in a few weeks here, but it has very good feedback. We found that you're able to do a lot in the anatomy lab with the growth specimens, and I would just like to comment that Dr. Zipla, our neuroanatomist, is fantastic, and I think one of the best teachers I've ever worked with. So it's great that we have him.
We do have a version for medical students who are going into not just neurology, but related fields, including psychiatry, neurosurgery, orthopedics, radiology, pathology. And many of the residents mentor the students, and that's a 2-week elective in the spring that also involves going back to the lab, doing brain dissections, and it's very heavy on imaging and correlating that with the specimens. So it's similar to what the residents get, but obviously the residents are at a higher level. There's one question. How do you consider signaling in the application process? I would, Andrea, I'm comfortable saying we don't consider it very much, except to note maybe that there's a regional interest, but the lack of a signal does not hurt anyone at all. So I don't think it sways us much at all one way or the other. Did you want to add anything to that?
No, last year was our first year with signaling, and it felt like we didn't use it too much. I think it was sometimes helpful to know what people's interests are, but if they didn't have a signal, it didn't matter. But I think if that's something that you choose to do, that's totally fine. If you choose not to do, that's fine as well. We again look at the entire application and consider the whole package and not just whether someone signaled or not.
Okay, another question. Could you talk a little bit about exposure to headache medicine and pathology? And I know who can take that question.
I'd love to take that question. I want to take it back to when Khan was talking about the VA kind of tailoring your interest as from when you're a resident. And I expressed very early on that I had an interest in headache and neuro-ophthalmology, and that was encouraged, supported, and mentored. And I started seeing a lot of headache patients in my COC clinic, both at the VA and at the university, actually, very early on as a resident. But we didn't formally have a headache division or headache faculty at the university. Yet still that was very supported, and I was encouraged to pursue it. And after I completed my fellowship in neuro-ophthalmology, and in that fellowship, I also saw a lot of headache patients, and it continued to be encouraged through my fellowship. I'm happy to say that now we have formally a newborn baby headache division with myself as a faculty and my colleague Ryan Lechtenberg, who is a general neurologist, who's also part of the headache division, and 2 nurse practitioners and 1 clinical pharmacist that is working with us. And like I said, we're just getting started, but there is going to be a lot more exposure, and we do have a major, big, enormous population of patients in need. So there is a lot of pathology to be seen, from bread and butter cases to more complicated patients. And the plan is we're building up a whole headache curriculum. We're also just been granted a scholarship through the American Headache Society. So we're actually, it's called the REACH program, and we're going to have didactics and grand rounds sponsored by the American Headache Society for the residents and also the faculty, whoever's interested in learning about this. We're having more tutorials on training for Botox, and we're doing a lot more of those procedures, both Botox, trigger point injections, and even trying to build our own sort of infusion clinic as headache medicine kind of builds into this state-of-the-art subspecialty where we have our own, dedicated medications and infusion centers and all of that stuff. And so it's exciting. It's an exciting field. We're growing. We're just getting started, but it's looking very promising. So there's definitely going to be a lot of opportunities to learn on the headache field and grow with us.
Yeah, we're very excited about the headache program and really want to support you and the team any way that we can. It's very cool. Another piece of that question was pathology. So I'm assuming that was neuropathology. And we do have a lot of opportunities for our residents to get involved. I'll start out talking about one of my favorite conferences of the week, which is our weekly muscle path conference with our 3 muscle pathologists. And it is incredible. We see cases from our clinics, also cases that are sent to us from around the country. We have a world-renowned muscle path group, and a lot of places have set up a system where they send their muscle specimens directly to us. Also, if a muscle specimen has been looked at elsewhere and they need a second opinion, they send it to us as well. And it's a really incredible meeting. We have it in person at a multi-headed scope, but then we also do a Zoom, a virtual option as well. And I feel like I learn a ton that week, and also know how much I need to learn about muscle pathology. But that's a really great conference that's weekly. There's also a tumor board that takes place every Tuesday morning with neurosurgery, neuro-oncology, radiation oncology, and neuropathology. That's also a virtual option for residents to jump on that. There is brain cutting that I believe takes place every week that residents can go and check that out. And we do work really closely with our neuropathologists. They do a lecture series with us, as well as a CPC conference where we will oftentimes discuss an autopsy case that was on our service. So definitely a lot of neuropath exposure and really phenomenal experts that we work with.
I can add a couple things to that too. So I've been involved with autopsies before. It's very informative and a lot of fun. And the other thing that I've been doing through research is I do a lot of neuropathology in my own research. So the part of my project involves looking at brainstem nuclei and looking for neurodegenerative proteinopathies, including synucleinopathy, amyloid pathology, and tauopathy, and correlating that with neuropsychiatric symptoms. So I do a lot of neuropathology too from a research standpoint, but you can choose to do different types of neuropathology through research, and it's not something that I've done in the past. It's just something that I started to learn in Iowa, staining sections and looking them under a microscope, and so.
We had another question about headache that I'll turn it back over to Adriana.
Sure. I'm going to read the question. Someone asked, glad to hear about the headache medicine experience. Would you consider teaching Botox injections and TPI for residents and maybe setting up a headache fellowship in the future? So thank you so much for that question, because yes, we are actually planning on teaching Botox and TPI. We're setting up a workshop with AbbVie representatives. Actually, that happened when I was a resident, and now it's happening again. So we're going to do a live training session for the residents on Botox injections, but we're also going to have exposure live in the clinic because the nurse practitioners and both Ryan Lechtenberg and myself are doing Botox for our patients. So there's going to be more opportunities for practicing and exposure to these procedures. And definitely, as a newly born headache division in this great academic center, the goal is also setting up a headache fellowship in the future. Yes.
I think we've gone through all the questions that have been posted. Are there any other topics or questions that haven't been addressed that people want to type in real quick? You're supposed to wait 7 seconds when you ask a question like that, and it seems like an eternity. I usually do it in my head, and you'd be amazed at how many times at the 7 second mark someone asks a question. But not this time. Dr. Swenson, did you want to say anything in closing?
Yeah, thanks again for joining us tonight. And I encourage you to check out our website. We've got a lot of information on there. And reach out to us if you have any questions going forward. Oh, we did get a question.
How's the cafeteria food? I wouldn't know. I never eat it. Actually, I have had it. It is fine. There are food carts in the warm months on Thursdays, food trucks, which are great. There are a few different cafeteria options, 2 different coffee houses. And yeah, so I'll let maybe the residents answer that question.
I think it's fine. I don't love the food a lot, but I eat it. And also it's important to note that as you have more call time, like as an intern, I think you get around 600 like call money to pay for the food. And then depending on the amount of calls during the second year, I think it's around that. And third year, it gets a little bit less because you have less call. I might not be accurate with the number there, but you get a lot of money for the food as well. So, and we also have another like a coffee shop that has sandwich options and pastry options, a lot of coffee. Yeah.
In the to be fully transparent, the PA food is not good. It is not good. But I think the main hospital is fine, if anything. I'd say above average at some of the cafeterias. I would avoid the VA cafeteria.
And I can second that you do get plenty of food call money. Just don't eat sushi every day for 2 months for lunch. That's a good way to run out. But otherwise, you get a good amount. So
Turns out my 14-year-old is a freshman this year, and my wife gets a ding every time it reloads his money. And school started 2 weeks ago, and he's had to reload twice already. So he's eating a lot of pizza. And yeah, we do have when we have after hours meetings and certain events where we expect residents to attend, we do provide food for those, including pizza, but sometimes things that are healthier or more variety. So we try to mix it up. Caroline is great about being both cost effective, but also finding really tasty options.
We also have a free food option when an external grant round speaker comes in to give a lecture. And 1 hour before the lecture, the grant round speakers meet with the residents for an hour. We have scientific and clinical discussions, and then we eat our lunch during that time frame as well. So
I gotta add to that, we have many talented residents who every once in a while bring their baked goods with them. I've been pretty impressed.
Yes, I second that. It's delicious, the stuff that they bring in.
And now that we're all hungry, maybe we can adjourn. Thanks for joining, everyone.
Thanks again. See
Thank
you.
you.
Thanks
Thank
all
you.
and good luck.